We need to talk about the interaction between lens and cornea. And we obviously have to talk about when do we do lens, when do we do cornea. That's coming after this. She should have done it the other way around. But so in this respect, I have a number of cases just to illustrate everything. So case one is going to be a cataract, actual cataract, where the patient ends up target plano, and then comes back and says, no, I want better. Case two is a cataract where we target hyperopia and then do blended vision. Case three is someone has some lens changes, but we do LBV PRESBYOND anyway with special counseling. Case four is a demonstration of cataract surgery after PRESBYOND, with an IOL chosen according to the spherical aberration of the cornea. Okay? Case five is, I'm glad I stuck to the London Vision Clinic standard protocols for treating presbyopia without a cataract. Okay? I'm not telling you any more. Okay, so case one is the patient who presents, 52, he's telecoms engineer, he has the belt, he goes up the pole, he does the things up the pole. He had a heart attack, he's on all kinds of medicines for that. No ocular history, driving glasses, wants better distance and reading without glasses, but also notices glare while driving. And his surgeon did this evaluation and got 20/30 best corrected with a little bit of low myopia. And this was the topographies, and this is the cataract that he had. So it was cataract, right? There's no way of saying, that's not a little bit of cataract, that's cataract. So he has cataract surgery, and his pre-op OSI was this. And so now the question is, what treatment would you recommend for this patient? None, wearing glasses and wait for a few years to allow the lens to change more. PRESBYOND, multifocal corneal laser surgery. That's to catch the one who was sleeping for the last day out. Lens surgery with monofocal IOLs, with or without monovision. Lens surgery with a trifocal, and then presbyopic corneal inlay. So give me a show of hands or say something. Lens surgery, D.
It depends.
No, that's all the information. No, you have to choose.
Yes.
No, you have to choose.
As a retinal surgeon, I would tell you have to look at the vitreous.
Oh, okay. Okay, so if the vitreous is attached, okay, if the vitreous is attached,
If it's attached,
52, low myope, what are you going to do?
of course you have to check if it's a high risk for detachment. You're going for laser. If you're going for the laser, you're not.
Laser with a 20/30, patient's 20/30 best corrected, barely driving standard.
Yeah, well, when you do the cataract, you still have to be cautious because.
Well, when we know that. But I mean, this case is kind of interesting because it's 20/30 cataract. That's not a little bit of cataract. That's a problem. So, of course, we understand vitreous, and we understand that very, very much more than most anterior segment surgeons. You're a posterior segment surgeon, but we understand it better than most anterior segment surgeons. We make it an argument for no clear lens exchange, okay? But a lot of people do clear lens exchange with vitreous attached in myopes with eyes that are longer than 23 or 25 or even 26. They still do it. They got the -9 when they do put trifocals in, even though the vitreous is attached. People do it. Anyway, so the answer is he had lens surgery with a monofocal, okay? So we referred this patient to a cataract surgeon outside of the clinic, and he had the right insurance that he could pay for it. And so he did bilateral distance vision. And he came back 4 years later saying, look, I want more near vision. And so we left him and referred him out with this refraction, and he came back, with a mini monovision, but he wanted more near vision. So, by the way, because we had his pre-op OSI, we could see that his OSI was greatly improved by the cataract surgery, and his topography obviously hadn't changed much, and the cataract surgeon we sent him to does a beautiful capsulorhexis, so everything looks crystal clear, there's no PCO, it's A-OK. So, what are we going to do? Well, the guy is plano minus a quarter and minus a half minus a quarter, and we're going to do PRESBYOND. And what happens is that post-op one day, he looks beautiful, and his 3-month, he is completely amazing. 2012, N4, intermediate is N4, and that's great because he climbs up poles and looks at all those things with all those little wires going everywhere. And from his patient perspective, he sees perfectly at distance and at intermediate. His night driving is great. And sometimes he puts on +1s when he's getting into the little wires here and those things that you see in the street. You better not put the red wire next to the green wire, is the whole point, right? But that's an example of someone who's had cataract surgery, was rendered not independent sufficient, and then had PRESBYOND on top, and ended up practically completely independent of spectacles, thanks to PRESBYOND on the cornea. Case 2. This is different. We call this, in our clinic, I call it, facetiously, I call it premium cataract. You know, what do people call premium cataract surgery? Premium cataract surgery is whatever it is with a multifocal IOL. That's premium cataract surgery. We have a designation called premium cataract surgery, comma, no really. And that's this. You've got your 68-year-old who's a jazz musician, good health, no medications, no family history, no ocular history except being -5 most of his life. Single distance vision only, glasses since 1957. Came in because he noticed a deterioration in his vision over the last year. Also, he's having a little trouble reading music while at the piano. His exam was best corrected 2050, and he was wearing -5 glasses, but he was actually now -750, or -8 in the left eye. And so he had cataract. And he had very nice corneas, no problem with that. And his slit lamp exam showed little, almonds inside his crystalline lens. Beautiful, beautiful cross sections. They're juicy. So, A, B, C, D, E, or F.
How old is he?
68.
68.
And real cataract, 2050. So according to Fernandez's study, because his OSI is going to be 6 or something, you put a trifocal in this guy, he's going to be super happy, right? Because he's got a terrible OSI, and you're going to bring it down to just bad. Okay? So you can get it down to a +1, like a 1.5 OSI, and that's reasonable for me. LOX2 cataract isn't necessarily a cataract that you remove. So, from Fernandez's study, right? This is the first objective study of OSI and trifocal lenses, where he determined that after surgery, a trifocal patient ends up with an OSI of 1.5 on average, and that's the equivalent of LOX2 cataract. And so don't do one that's less than LOX2, because you're making them worse, is what he's saying. Well, we did lens surgery with a monofocal IOL, but he lives in Florida, in Clearwater, Florida. Is that near you?
About 2 hours.
Okay, well, he had an ophthalmologist in Clearwater. And I called the guy and spoke to him, and I said, look, this is what I need you to do. I've looked at his spherical aberration on the cornea. And what I need you to do is I need you to target the right eye at whatever, +2,375, and the left eye at +1, 1.4 or something. I calculated what I needed for the post-op hyperopic outcome so that I could then do PRESBYOND and get the best out of him. So I had this long discussion about multifocals, monofocals, monovision, laser blended vision in combination with multifocals. My recommendation is to have cataract surgery in both eyes with implantation of a high quality monofocal IOL, such as the Acryos BNL. and target refractions of whatever. I had different targets, but astigmatism can be left entirely alone. You just put spherical lenses in, because I'll do all of that on the cornea later with the PRESBYOND procedures. And I drew the diagrams for him, and he had his cataract surgery. He was put back in spectacles. Obviously, he couldn't see. He was hyperopic. And he was about a year in these hyperopic spectacles, and finally he texted me and wrote me an email, said, look, I'm ready to go to stage 2 here. So he came to London and took an Airbnb, actually near my house, and we spent a week here, and this guy did a great job of targeting the dominant eye more than the, I think I said about 150 here and a little over, I said 225 there or something like that. The guy did a very good job. The guy ended up on target. CDVA in the right eye wasn't quite 20/20, but the capsule was clear, so that must have been a myopic retinal problem. His cornea still looked great, and he'd done a YAG, but as you can see, that there wasn't a full capsular polishing here, so he had quite a bit of a reason for a YAG, a lot of pearls and epithelial cells. But nevertheless, his visual axis was crystal clear. So I did PRESBYOND on him, and on post-op day 1, he looked beautiful. And at 8 months post-op, he had his best spectacle corrected as uncorrected in his dominant eye. He was plus a quarter and minus 1.375. And his near vision was N4, and his intermediate was N4, and his distance was 20/25, because that's what his eye does. And this guy, and here's his OCTs, which look very nice. There's his flaps. This is what his topographies look. Huge, huge, massive hyperopic optical zones, which you get with the MEL laser. And this musician is Chick Corea.
Did you guys play together? Please tell me.
So, oh, sorry, could you? Okay, so I'll get to that in a second. So we did the surgery, I think, whatever, Monday, and he came over for dinner, I guess, on the Wednesday or something. We're having dinner and we're talking. He's the nicest guy on the planet. So nice. And he says, we're just finished dinner. He goes, hey, Dan, let's go upstairs and do some playing. I think, oh. Sorry, up there in the booth, you see that link there, that YouTube link? It hasn't activated for some reason as a link. Well, first let me show you this.
He wrote out a little piece of music, and he wrote some left-hand notes as well. It was a song called Again, and it goes.
So he's looking at his fingers. He's looking up at the intermediate distance, which is this piano distance. Very difficult to get that. And then he looks out to the people he's talking to, out of the audience. And I want to show you what else he's doing. I just copied this off the internet.
What he did is he pointed to the note on the piano, and then at the same time
he's switching back and forth, no problem. Points to what he's with little note on the. Okay. So okay, let's go back one, please. And I just got to show you this. This is not on the internet. This is a private link. I wouldn't dare presume to put this on the internet.
You guys, go ahead and find a key that's good for.
There's only one key for the song.
Are you trying to change the key then?
Oh, I'm sorry. I was being a singer.
Singers always try to
See, they always do in B.
That's his wife.
I go around.
stay here for the whole 20 minutes, but I could. Incredible. So he, at the end, see if the captions pick it up. Yeah, no, he said something like, "You played just the way I thought you would." And I said, "That bad?" Anyway. All right, we can kill this thing. I had black hair back then. So let's go back to the presentation, sorry. So, you know, that's the sort of, that's the reason why I invented PRESBYOND. Literally, so that I could operate on my jazz idols, and I got a list of about 30 of them now. And the list is quite extraordinary. The list of people that I've done PRESBYOND on is just crazy.
You wrote a...
Really, honestly. Maybe if we have enough beers tomorrow over the bowling, I might divulge other jazz musicians who have benefited from blended vision. Anyhow, let's go to case 3. Lens changes, but we're going to do blended vision PRESBYOND anyway with counseling. Now, 54-year-old female, general health, a bit of depression, antidepressants, varifocals. Okay, wants to be glasses free. TV can be a bit glary at night. 2020 and 2016, -4 and -2. Interesting, -4 and -2. Now, we have a night vision simulator in the clinic, and we put her on it, and this is what she said can be a little bit glary. Well, that's not too bad. It's a lot worse with an IOL. Even a monofocal can be a lot worse than that. So, her topographies look great. Everything else was normal. Lenses were, yeah, as you'd expect, right? Perhaps a little bit of nuclear changes there, which might explain the -4, yeah? And a little bit more that nuclear shift here compared to the left eye, which might explain the -4, so she might have been -2 in both eyes before. Her depth of field was huge in both eyes already. So these lenses, these little nuclei in her cataracts are already giving her massive depth of field. So, explain to her that she may well need cataract surgery within the next 1 or 2 years. Or, you know, if we're lucky, she gets about 5 years without needing cataract surgery. But we have to talk about the balance of risk, right? She's a minus patient, and she's 54, and her vitreous is attached. And so, say, look, on balance, the lowest risk procedure right now is to have corneal surgery. But you need to understand that there may come a time when you don't have a choice anymore, and you do have to have lens surgery. Now you do have a choice. The refraction might shift. You might need another enhancement in that right eye or the left eye because of that. So we did PRESBYOND on her. We counseled this very carefully, documented everything. And she ends up plano, -138, target, and cross blur test, everything's fine. Targeted less than accepted because I knew that her right eye was myopicizing faster than her left. So I wanted to buy her some runway. So I didn't target her for 150, so she ends up 250 with monovision. I targeted her 138, so she ends up -2 in a year or two, and she's still fine and glasses free. And she ends up beautiful. And 2016, N4. On target, well, a little bit more myopic than target. This is at 3 months. And you can see it, right? You can see her lens changes. So there we go. I mean, this is a patient in whom we could have easily done it, but her OSI was 0.4 and 0.8. So you can have these lens changes that you can see at the slit lamp and you locks them out. But the fact is she has very little scatter. She doesn't have night vision disturbances. Yes, she's myopicizing, but it's not a cataract. And she's got a myopic fundus with an attached vitreous, and she's not in the age, she is in the age group where she's at higher risk of retinal detachment if she has phacoemulsification. So we've done the right thing for her at this point. Case 4, demonstration of cataract after blended vision with an IOL chosen according to the corneal spherical aberration. So this is the case that most people ask us about. What do we do if there's previous blended vision? Jonathan Clark back there is our amazing, super talented cataract surgeon. And so we have weekly discussions about, about choosing lenses, right? And so if we look at this patient, 65, golfer, glasses since 42, reasons for it wants better distance in reading, had 20/20, 20/25, was hyperopic. Contrast sensitivity was, totally normal. We still had manual charts. This is a very old chart. It must have been pre-2007. And that's the age normal. So her contrast was still good. Her topographies were like this. I had an orb scan because this was like 2000 and the date was 2007. Yeah, indeed. Ks were in the middle of the range, so that's fine. Corneal thickness nice and juicy. That's what her lenses looked like at the time, 2007. What did I do? PRESBYOND. What did she get? She got an amazing result. She was, by the way, we were treating plus 550, right? So remember, MEL 80, MEL 90, 7 millimeter zone, easily treat up to plus 650, no problem. But you have to center on the vertex, and you have to be able to measure the epithelial thickness profile post-op so that you know whether you can enhance or not, because that's the only way of doing it. It's nothing to do with the Ks. That's a whole other lecture, which I think we're talking about on Sunday. If you've already watched the therapeutic lectures, that's in there. And here is her stability curve. So we did her in 2007, and here we are, stability all the way out to 2017, absolutely stable, pretty much. The Ks sort of just grinding down a little bit. Manifest refraction of the left eye, pretty stable. Ks flattening out a little bit, but that's, from 2011 or so, she's been pretty much stable, completely stable. So starts off at plus whatever. 10 years on, she's plus 0.75 and minus 1. Not bad. Her vision has remained stable at 20/25 at distance, and now her cataract is starting to go in the left eye. Okay? So there was a 0.4 diopter shift in Ks in the right eye, 0.6 diopter shift of Ks in the left eye of flattening. Okay? So this is a long-term case of PRESBYOND, okay? 10 years. Her beautiful corneas, like this gorgeous, huge optical zones, and she's 20/30. So let's go through this. She's 20/30. Is she 20/30 because of some corneal topography issue? No, those are beautiful corneas. It's not decentered or something, right? Okay, so it's not the cornea. Is she 20/30 because of her lens? Yeah? Well, that's the left one. That's the right one. So is that a 20/30 cataract? Is that a 20/30 cataract? Well, that eye's 20/20. That eye's 20/25 plus 2. This eye's 20/30. Doesn't really look like a 20/30 cataract. Look at the retroillumination. There's no PSC. It's not like something weird. Well, it's not a 20/30 lens. This is her fundus. Oh. Wow. So, someone would have taken that woman in her 60s who's plus and said, laser can't treat plus, and you can't do LASIK in people over the age of 50, and this is the best procedure and it's the only procedure for you, and done a clear lens exchange with a multifocal, because that is bread and butter for a plus 3 or 4 62-year-old, right? Or 60-year-old, right? Bread and butter, classic case. You've seen thousands of them, you two up there, thousands of those, right? The OCT was normal back there. Her best spectacle corrected vision was fine. But as I said, 1 in 6 Anglo-Saxons will develop macular changes later. And so Good thing that we didn't put in a multifocal at that point. And remember, we talked about this. 1 in 6 patients that were followed properly in an arm's length study over 3 continents found that this is what's going to happen. And we also learned that, we also know from this paper from the Beaver Dam study, no, it was the Blue Mountain study, that cataract surgery and the 5-year incidence of late stage, in other words, patients who had cataract surgery were followed for 5 years, and the same age control matched everything patients at the same age who did not have cataract surgery were followed. And they compared at 5 years the two. And those who did not have cataract surgery, 0.7 of them developed AMD. Those who had phaco, 6% developed AMD. So the implication here is that phaco itself may be a catalyst for accelerating AMD. And it's not a stretch to imagine why that would be, particularly if the vitreous is attached and you're starting to mess around with things that could affect blood flow and whatever around Bruch's. So here's the glad I stuck to the LASIK protocols for presbyopia in the absence of cataract, right? 68-year-old female. Actually, I think that was the case. I'm getting confused, but let's just carry on. 68-year-old female, right? So presents with a CDVA of 20/50 in the right eye, 2016. And we've got her records that she was minus 175 5 years before from her optometrist. So we know that this refractive shift isn't related to her cornea, it's related to her lens. The best spectacle corrected vision's gone down, so we know that she's got a cataract in the right eye, not the left. And her wavefront in the right eye shows, oh, this is the last case, sorry. So the wavefront in her shows that she's got minus 323 spherical aberration. So she has right eye surgery cataract performed. At the 1 month, she was targeted for minus 175. She's N4 with just minus 175. And her left eye is still 20/16. So how did we calculate this lens? Well, she had had, by the way, I'm sorry, she had had +2 LASIK. I think that was on the slide, wasn't it? Am I wrong? I'm getting confused. Person 8 years, oh yeah, 8 years before she had had PRESBYOND by me for +2, sorry. All right, okay, sorry, I missed that. I'm a little discombobulated from watching me play with Chick Corea. He died last year, sadly, he died last year. I've got a beautiful watercolor that he drew for me, representing what PRESBYOND does. It's in my office, you'll all see it on Sunday, it's on the wall there. So she comes back all those years later, myopicized with best corrected loss. Okay, now we're back in the saddle here. So how did we choose this IOL? Well, here it is. First of all, the power calculations is the same as you would use for any other LASIK patient because, remember, PRESBYOND doesn't make weird topography post-ops. It's not like a PresbyMax that's a multifocal cornea. It's a regular LASIK. And so Haggis, Haggis-L, Barrett True K, these formulas work really well. So you can go and plug it all in, try it as much as you like, compare all the different formulas. Our experience is that the Barrett True K after PRESBYOND works perfectly, like really perfectly. And right, Jonathan, you've been impressed? I mean, it's pretty accurate. And so we go back to our principles here. We have the spherical aberration of the cornea on the visual axis, and we want to keep it within the therapeutic range, not the toxic range. So we look at the spherical aberration that's on the cornea, centered on the visual axis. So this is not a wavefront sensor measurement, it's a corneal topographer spherical aberration measurement. Somebody was asking me about cornea versus lens and whole eye. So here, for cataract surgery, we're taking the lens out. So we want to know what's on the cornea. And now we're looking and we're trying to pick a lens that will help push the final spherical aberration onto the target zone. So in this case, we use the Osiris, which is the highest resolution wavefront sensor in the world, and it does quite well through cataracts, better than most because it's so high resolution. We have the corneal spherical aberration that we're trying to target the final with, and we have the internal, which is what the IOL that we're going to choose. And obviously we're trying to, look at these three factors, and the first thing we look at is the corneal, plus 0.71, okay? So now she has plus 0.71, so now we have to pick a lens that will alter the spherical aberration and push the spherical aberration onto the target zone. So what kind of a lens do we want in her?
So this was a hyperopic ablation, or
It was a hyperopic ablation.
and she finished with positive spherical aberration?
Yeah, it's really weird.
Yeah.
We want a minus IOL because she's got too much spherical aberration on that cornea. So we want to draw that below 0.6. So we use an Asfina, I can't remember, the Zeiss has this weird nomenclature. I actually made a note here because I can never remember, because I'm not using these all the time. I can never remember the 506 or whatever, 0.1, the 0.12. Actually, we didn't do Zeiss. I think we used the, so, hang on. I think we used the, okay, this is just another example. So, okay, so this is, we use this one, which I think may be the Lucia, right, yeah. That was the secret. Okay. It's a cheating. Okay. Over here, I think another example. Now the cornea has plus 0.2. So now what are we going to use? An MA60AT. Because it has a lot of positive spherical aberration. Like straight Alcon foldable. Pushing the spherical aberration up to 3.34. Yeah? So,
Just real quick.
yeah.
Those maps, you're showing us an Osiris scan, an MS39,
So this is a combination of the Osiris with the MS39.
and a software program grabs a difference map for you?
The software will tell you what the whole eye is, what the cornea is, and what the internal is.
And it has to get that internal from both machines.
It subtracts ones from the other. But of course, the internal is irrelevant because we're taking it out. What we're really interested in is the cornea.
That's a posterior cornea.
Yeah, Tim, does it include the posterior? We were actually trying to calculate that. It does not include the posterior cornea. It does not. The internal one,
The corneal aberrations include posterior.
it does include posterior.
The corneal aberrations.
Front and back?
Yeah.
That could be why this is plus 0.71. Okay. Anyway, it's the total corneal. Yeah. Anyhow, that's what we would do here. Drive the spherical aberration up in this case. And here are these options that are either spherical aberration negative or spherical aberration neutral or induced positive spherical aberration. The amount of positive spherical aberration that the spherist lenses induce depends on the power of the lens. So the higher the power of the lens you're going to put in, the more spherical aberration it induces because it's spherical. So the bigger the power of the spherical. So like if you were trying to treat a high hyperope, a plus 30 eye, you're putting a marble in the eye. I mean, it looks like a marble. It's totally round, right? It's a lot of spherical aberration. Probably too much. Anyhow, so, we know about multifocal IOLs being very successful in the marketplace, and a lot of patients are happy. But PRESBYOND and cataract surgery together give us and our patients higher quality of vision, more accuracy in refractive result, reversibility of the anisometropia if required, and adjustability over time, because the cornea is not a piece of plastic. And we know that the cornea will change in a third of patients by a diopter of SIL in 5 years. So permanent vision correction is not lens surgery. You'll still have to adjust on the cornea if they want to maintain that vision over time. And the idea here is that we can tailor our lens choice based on whatever level of spherical aberration is in the cornea from the previous LASIK, even if it's from another clinic, even if it wasn't PRESBYOND. They had a -8 correction. You're probably going to put a Technis minus 0.27 in, because you want to really suck that spherical aberration out of the cornea. So you understand, the choice is it's just simple arithmetic. What is it on the cornea? Let me see which lens I can put in that's monofocal. Put that in, and Bob's your uncle. And then you do your blended vision tolerance testing and all of that. So in summary, these are the sort of 5 scenarios to do with lens and PRESBYOND. Okay.